Surgical anatomy. The nasal envelope, also known as skin and soft tissue envelope, is the skin that covers the exterior of nose. The nasal envelope is made up of soft tissues and includes all intranasal soft tissue except the osteocartilaginous framework. The nasal envelope consists of the following layers from superficial to deep: epidermis, dermis, subcutaneous fat, muscle and fascia, musculoaponeurotic layer, deep areolar tissue, and perichondrium or periosteum overlying cartilage or bone. The nasal skin is very specialized organ keeping its own shape and characteristics with differing from other parts of body. In short, it especially at thick nasal tip keeps its own shape and pattern. It is an evidence of difficulty for change at nasal tip with surgical manipulation. Therefore, it is important to evaluate individual characteristics of patient's skin before the operation to make surgical plan and predict prognosis, because manipulation on cartilage framework is not visible due to thick skin during tipplasty. Thinner skin tends to reveal even minor changes to the underlying framework. Therefore, patients who have thinner skin can be more challenging because there is less margin for error. The nasal skin of dorsum is the thinnest, less sebaceous, and more mobile, hence can be shortened and wrinkled by a facial expression. However, it gets thicker caudally and is the thickest at supertip area. The dermal component of the skin is thinnest over the rhinion and thickest in the supertip area. The subcutaneous layer at the alar groove is very dense, hard and tightly attached to underlying tissue. An alar skin is considerably firm with tightly wrapping fibrous tissue. On the other hand, the columellar skin gets thinner and less sebaceous. The external part of columellar skin is tightly attached to medial crura and connected with vestibular skin internally. Zones of the nasal skin. Zone 1 covers the upper dorsum and side walls of the nose and characterized by smooth, thin, and non-sebaceous skin that glides easily over the underlying bone and cartilage of the nasal hump. Zone 2 begins about 1.5 cm above the supertip area and covers most of the nasal tip and alar lobules and to within 4 mm of the alar margin. Skin is stiff, thick, and filled with sebaceous glands. It is underlined by a layer of dense fat, which is 6 to 10 mm thick in the region of the supertip. Zone 3 includes a 4 mm strip along the alar margin, the soft triangles, the lower half of the infratip lobule and the columella. Skin is smooth, thin, and non-sebaceous. There is little subcutaneous fat and fixed to the deep cartilage and fibrofatty structures and does not move easily. The medial and middle crura and their intercrural groove are visible through the thin skin of Zone 3. The superficial fatty layer is thickest at the nasal radix and thinnest at the rhinion. The fat pad of the nasal radix is located over the procerus and extends to laterally medial brow and depressor supercilii. Fat pad of the supertip and sidewall is densely attached to dermis. The interdomal fat pad is located caudally from supertip fat and between both medial and middle crus. Nasal muscles. Fibromuscular layer. The fibromuscular layer is the core part of nose, consisting of nasal superficial musculoaponeurotic system, SMAS, along with a superficial fatty layer. The main function of the fibromuscular layer is to allow movement of the nasal envelope, to offer blood supply and to maintain the thickness of the skin. They also integrate and transmit the contractile force of nasal muscles. Nasal muscles can be identified following their topography, shape, and color. This is the anatomical basis of the so-called medical rhinoplasty. All these muscles form a unique musculoaponeurotic layer, so-called nasal SMAS. This layer is separated from the bony, cartilaginous framework by connective tissue, which is the right plane for undermining during rhinoplasty. The procerus muscle covers the nasion lying between the frontalis muscle cephalically to aponeurosis of the transversus nasalis muscle caudally. In some cases, it can be considered as a muscular link between the frontalis muscle and the nose. It gets adherences to the periosteum of the nasal bones and to the perichondrium of ULC, close to the midline of the dorsum. The transversus nasalis is adherent on the midline over ULC, forming a common aponeurosis which is part of both symmetric muscles. They are composed by two expansions. The caudal one inserts onto the deep aspect of the skin, and the cranial one intermingles with the lateral part of the myrtiformis muscle, covered by levator labii oblique nasi. The levator labii superioris oblique nasi inserts on the frontal process of the maxilla and splits into two chiefs. One goes to the philtrum of the upper lip, the other one to the ala of the LLC. The dilator naris forms the lateral framework of the nostril. It is located between LLC, nostril's margin, and piriform aperture in an anatomic area absolutely free of any cartilage. It has also been sometimes described as part of the levator labii superioris muscle, so forming the deep levator labii superioris. The compressor naris major and minor are accessory and inconstant muscles which lay in the subcutaneous tissue over the tip area, especially when LLC lateral crura are concave. These muscles are located in the concavity of these cartilages and get insertion on the nostril margin. The myrtiformis from the myrtiform fossa splits into an anterior chief which goes to the upper lip and a posterior chief which inserts on the nostril's floor. The depressor septi nasi muscle. The muscle goes from the orbicularis oris muscle to the skin of the columella and inserts on the feet of LLC medial crura after having split into anterior and posterior chiefs. Michele Pellegrini, 2005, has proposed a classification of facial muscles dividing them into three groups depending on their bony insertion: inserted, semi-inserted, and not inserted. On the nose, only semi-inserted and not inserted muscles can be identified. From aesthetic point of view, many nasal muscles are involved in determining the aspect of the profile, affecting the nasal frontal and nasal labial angles. Surgical procedures performed on the myrtiformis or the depressor septi nasi muscles can be useful to open the nasolabial angle, to rotate the nasal tip, or to lengthen the upper lip. In the same way, to deepen the frontonasal angle, muscular resection of hypertrophic procerus muscle has been proposed. Depending on anatomic variations of frontal process of the maxilla, in some anatomical situations, levator labii superioris oblique nasi muscle may insert very high onto this bone. In these cases, lateral osteotomies carried, low to low, from piriform aperture, without periosteal elevation, can cause hematomas and partial postoperatively upper lip ptosis due to direct muscle trauma. The levator labii oblique nasi assists in maintaining the patency of the external nasal valve, while the depressor septi nasi acts to shorten the upper lip and decrease tip projection. There are two natural planes of dissection. One is the plane between the subcutaneous fat and muscle/fascia, and the other is between the deep areolar tissue and the perichondrium/periosteum. Laterally, there is no dissection plane between the dilator naris muscle and the external nostril skin. On the contrary, during alar base resection, it is possible to remove only the nostril skin, leaving the muscle intact in depth. Nasal SMAS injury during rhinoplasty. Partial or total accidental loss of nasal SMAS during hump removal can lead to adherences between dermis and cartilaginous/bony framework. If it happens, many consequences can occur. The cartilaginous and bony framework become visible under the skin. Open roof syndrome can occur due to adherences between the internal nasal mucosa and the external dermis through the hiatus of the open roof. This syndrome leads to pain and vasomotor problems. Adherences between skin and nasal framework are extremely difficult to dissect if a revision is needed. Skin injuries, perforations, scars, and retractions can occur. Neoangiogenesis and telangiectasia of skin over the nasal dorsum can be observed. Nasal cartilages.